All right. Thank you, Lori. You'll notice there will be some things that I'll go over again that have already been spoken about this morning. The primary focus of the next 15 minutes is going to be speaking specifically about surgery and focal therapy, which are two of the options for treatment for prostate cancer. I don't have any disclosures that are relevant for the content of this talk. Just to kind of reiterate the general landscape of prostate cancer treatment, we already just heard a bunch about active surveillance, which, as Lori mentioned, is really on one end of the spectrum, this close monitoring of cancer without active treatment. And then on the other end of the spectrum are these traditional treatments for prostate cancer, whole gland treatments, either removing it surgically or doing radiation therapy to the entire prostate. And then in between those is this idea of focal therapy, which is think of as partial prostate ablation for localized prostate cancer. And again, my primary focus is going to be talking about prostatectomy surgery and about focal therapy. Now, before we launch straight into treatment, though, we have to make a diagnosis. And so because normally localized prostate cancer doesn't cause any symptoms, most of the time this diagnosis is based on an elevated PSA, which then, if abnormal, is traditionally led to a prostate biopsy, which, if that shows prostate cancer bad enough to need treatment, would result in surgery or radiation. This is the way that this has worked for many years. When we think about the biopsy part of prostate cancer diagnosis, it's a little bit complicated. With many other types of cancer, so another one that I specialize in is kidney cancer. When kidney cancers develop, they generally form a discrete lump of cells that's quite easy to image, whether that be with ultrasound or CT or with MRI. And so when you have a very clear image of where this thing is, you can biopsy it, just put one needle right in the middle of it, and know very quickly, is this cancerous or not. Prostate cancer has been more difficult because we didn't have the same degree of imaging quality, and the cancers don't form that discrete lump of tissue often. And so it makes diagnosis somewhat more difficult. The imaging modality that we've had available to us for many years is ultrasound, and here we see a sample image of a transrectal ultrasound of the prostate. And what ultrasound does very nicely is it tells us where the prostate is. I've outlined in red here to tell us where the edge of the prostate is. So you can see that very clear. What's less clear often is where the cancer is actually located within the prostate. Sometimes that's visible on ultrasound, but very often it is not. And without an imaging modality that does us a great job of showing us exactly where the cancer is located, we haven't been able to do image-targeted biopsies as well. So instead, the way prostate biopsy evolved is with more of a random or systematic technique, where instead of aiming at one spot, we put, say, 12 needle samples evenly spaced throughout the prostate with the goal of finding cancer just by chance, largely. And that works frequently, but as you may imagine, there are sources of error, such as depicted here. You might just miss the cancer, this red oval here, just by chance if the needle happens to glance off to the side. And it also does not do a particularly good job of localizing exactly where the cancer is located and where the borders are. Fortunately, though, we've had rapid growth in the use of MRI for prostate cancer visualization, and this has really proliferated a lot over the last 10 years. The ultrasound image being on the left, the MRI on the right. With MRI, you see a lot more of the anatomy within the prostate, and it's much more likely to show abnormal areas, such as what the red arrow is pointing to, so that we can target a biopsy and get a better chance of finding that cancer. Along with MRI has come a new technology called MRI ultrasound fusion for targeted prostate biopsy. And in this case, rather than going straight to biopsy, patients will get an MRI frequently first, where a radiologist can go in and look and see, are there any suspicious areas? And then when they're reading that scan, they'll also outline the prostate in multiple different planes, and thereby generate a three-dimensional model of the prostate based on MRI. And then at the time of biopsy under ultrasound guidance, a urologist can do the same thing essentially, outline the prostate in multiple planes, generating a 3D model of the prostate based on ultrasound. And this biopsy device then can overlay those two models so that a urologist in the clinic can target things under ultrasound guidance and biopsy them, even if that abnormality is only visible on MRI. And indeed, there have been a number of publications over the last decade that have showed significantly improved prostate cancer detection diagnosis with this technique compared to the conventional mapping biopsy technique that I described a moment ago. So what's the next evolution of this technology? Well, Lori talked about it a minute ago, this idea of transperineal prostate biopsy. And I have the same figure in this talk as she showed earlier, this cartoon of a man laying on his back. And what we can see here is the traditional transrectal route, as Lori had mentioned. The needle goes right through the wall of the rectum into the prostate, which can find many cancers, but as we all know, the inside of a rectum is a dirty area. There's a lot of bacteria in there. And that can lead to fairly high rates of infectious complications where you're putting a needle through a dirty area right into the prostate that can lead to urinary tract infections or bloodstream infections that at times can even be life-threatening. Conversely, this transperineal route involves putting the needle through the skin behind the scrotum. And that area can be sterilized. We can clean the skin on the outside in a way that we cannot do through the rectum internally. And by doing that, we're able to significantly reduce infectious complications. We actually don't even need to give preventative antibiotics at the time of this procedure. And there is some suggestion that it actually increases the cancer detection rates by doing transperineal biopsy. So about 2 years ago, I shifted completely and only do transperineal biopsy for prostate cancer diagnosis. Okay, so now let's say we've made the diagnosis and we find, okay, there is cancer that warrants treatment. What are the options going to be? So let's talk for a few minutes about prostatectomy, or surgical removal of the entire prostate. This is by no means a new operation. Okay, it was initially described way back in 1905 and was modified significantly in the mid-80s by a famous urologist named Pat Walsh at Johns Hopkins, who described the nerve-sparing prostatectomy, whereby nerves and blood vessels that are just outside the prostate are preserved during surgery, which can help reduce some of the side effects of the operation. And then the next great innovation was the advent of robotics. So the first robotic prostatectomy was described around 2000. And since that time, that's really taken over, such that the vast majority of prostatectomies done in the US nowadays are done with a surgical robot. Why do we think that prostatectomy is a good thing, or how do we know that it's helpful for some men? I want to highlight one key study that was run in Scandinavia, initially began back in 1989. And what the investigators in this study did was they took hundreds of men and they randomized them. So essentially, heads, you get surgery; tails, you get, in this case, watchful waiting or no treatment. And the question is there a difference in deaths from prostate cancer if you have surgery versus you have nothing? This figure is an important one from one of these publications, and I'll take you through what this means. So if we look at the x-axis, or the horizontal axis along the bottom of the image, we see time. You see 0, 3, 6, 9, 12, 15. That's years after intervention. If we look at the vertical or y-axis on the left, that's the probability of death from prostate cancer. The black line that's crawling up the screen are men who had prostatectomy surgery. The gray line are those who had watchful waiting. And if prostatectomy is doing something, we should see those two lines separate over time. And indeed, that is what happened. You see the prostatectomy line being lower, which means that fewer men are dying of prostate cancer. And specifically, in an update to this trial, 23 years after this initial randomization, what was seen is that 18% of men who had surgery died of prostate cancer, and 29% of those who had watchful waiting died of prostate cancer. So what does that mean? Well, first of all, There are still men who die of prostate cancer after surgery if that cancer had escaped prior to the time of the operation. But fewer men are dying if they have treatment as opposed to no treatment, by 11%. Okay, so this is the justification for doing something, that there are fewer deaths by intervening on that cancer. Now, skipping back to the robotic approach, I mentioned this started in 2000 and has really picked up steam since then, such that most trainees nowadays coming out of training don't even learn how to do open prostatectomy anymore. Almost all of it is robotics. So with open surgery, we used to make an incision from the belly button down to the pubic bone. Nowadays, with the robot, we'll make 5 or 6 small incisions on the belly. And then through those incisions, we place access channels or ports, trocars, that we put through the belly in order to get access to the inside of the abdomen. And then the way the robot works is the arms of the robot snap on to each of those access channels, and we can place an instrument down through the port. The surgeon controls the robot through a console that's a few feet away from the patient. And so using your hands and foot pedals will control the motion of the instruments. So this is by no means an autonomous robot. This is entirely driven by the surgeon doing the operation. And I have a quick little video clip of a case that I had done, just so you have a sense of what the surgeon's actually looking at during the operation. You can see these 2 instruments from the right and the left hand moving around in here. On the bottom of the image, to orient you, this is the bladder, and then on the top of the image is the prostate. So we're pulling the bladder, separating the bladder away from the prostate, in this case using electricity to keep bleeding from occurring. And this is just one step of this operation, separating the bladder away from the prostate. So once the operation's over and we take the prostate out of the body, we'll give it over to the pathologist, who will cut it up like a bread loaf. So they'll create a bunch of different slices serially through the prostate, and then look at each of these slices under the microscope so they can tell us important information like the final grade of the cancer, how big was it, whether it was growing outside of the capsule or not. And you can also take pictures of that tissue, which is what we see here. This is essentially a picture of one slice of bread. And the pathologist has gone through and annotated in green those areas of the prostate that contain cancer. And what we notice here is that there are multiple different areas of cancer in this particular man. And his prostate's fairly chock full of tumor. There's a lot of cancer relative to normal tissue. Another key point I want to make, and that is, perhaps not surprisingly, but expert surgeons are able to get better results than non-expert surgeons. And how do you become an expert? Well, the same way you become an expert in anything else. You practice. You do a lot of it. So there have been a number of research publications that have shown that high-volume surgeons have patients that stay in the hospital for a shorter period of time, have less blood loss, have fewer complications, have a lower risk of leaving microscopic amounts of cancer behind, and have lower rates of urinary and sexual side effects. So better results from surgeons who perform more of these cases. Not to say that expert patients who are operated on by experts don't have side effects. They still do. It's just lower rates than people who don't do many of these. And indeed, side effects is really important whenever we think about any sort of a treatment for prostate cancer. We talked about even with experts we can have side effects, and what's important to note is that the majority of operations, prostatectomies done across the country, are not done by experts at high volume centers. They may be done by people who do a handful of these operations during the course of a year. So if we look at, well, what is the kind of average rates of side effects across the population, including both expert and non-expert surgeons, I just wanted to show this one figure here from a paper that was published several years ago. And again, I'll take you through this so you know what we're looking at. On the x-axis on the bottom, we see time since treatment. On the y-axis, we see a probability, in this case, of having erections good enough for sex at various time points over time. The green line are men who are on surveillance, so are not having treatment. The blue line is surgery. The pink line is radiation. So at the outset, in this population of men who are on average in their mid-60s. About 60% will say, yes, I have erections good enough for sex at the beginning. And then what you can see, if you have no treatment, that stays relatively stable at least over this 3-year period of time. That green line is relatively flat. The blue line, conversely, with surgery, you see this precipitous decline in sexual function right away after surgery, and then it comes back up to some degree. So some men do recover that function. But after 3 years, there's still a clear separation between the two. So you don't recover back to where you were beforehand. And both with radiation and surgery, you see them both well below where you would be without treatment. If we specifically look at those guys who had erections good enough, those 60%, the erections that good enough for intercourse before treatment, and then see what happens 3 years later, we see that 43% of men, so they were at 100% before, 43% now have erections good enough for intercourse if they had had surgery, and 53% with radiation. So a pretty significant decline from where they were before. Let's talk a little bit about precision medicine as it pertains to prostate cancer. So when I think about precision medicine, I think about individualizing treatments and treatment decisions based on a man's preferences, based on their age, based on their health, and based on the nature of their prostate cancer, so that not every man has the exact same thing done to them. And why is that important? Well, prostate cancer varies quite a lot. So I already showed you the image on the left with that prostate chock full of tumor, but on the right, this is an entirely different patient who's someone who had a prostatectomy, but you see the area outlined in green. This is a pretty small cancer, and there's only one of them. Yet for years and years, we've treated these two men exactly the same way. So it only stands to reason that perhaps we should be thinking about these two men differently. And from this comes this concept of focal therapy, which I'll define as the targeted destruction of cancer while preserving normal surrounding tissue both outside the prostate as well as elsewhere inside the prostate. So the idea of focal therapy is in somebody like this, maybe instead of removing his entire prostate, we could just zap that portion of the prostate, preserve the normal structure, and try to keep side effects to a minimum. This has been referred to as the male lumpectomy as an analogy to breast cancer. It has been shown to have reduced rates of treatment-related side effects while still maintaining good cancer results, and preserving the option for surgery or radiation should the cancer recur at some point in the future. Now, going back to that precision medicine part, well, not all prostate cancers, again, are the same. They can occur in different locations and different sizes within the prostate. So this is one example. We see the red arrow pointing to a cancer on the side of this man's prostate. This is a different patient with the orange arrow pointing towards a tumor that I'll call the front side of the prostate, so a different location. If we think of this patient with the tumor off to the side or near the back side of the prostate, a treatment like HIFU, which stands for high intensity focused ultrasound, makes a lot of sense. So what is HIFU? HIFU is kind of analogous to if you have a magnifying glass on a warm sunny day and you go out and you focus the sun's energy in a small focal point and, say, burn a little hole in a leaf. Except for with HIFU, we're not using the sun as our energy source, we're using ultrasound. But then taking that ultrasound energy, converging it on a small point that gets very hot very quickly, killing the tissue by heating it, and then a device can move that small focal point around to cover the entire area that we want to treat. And in this case, this probe is placed through the anus into the rectum into a patient who's under anesthesia, and then treat across the wall of the rectum into the prostate. This is non-invasive, so you don't have to make any cuts in the skin. It works by heating, so this is a different mechanism of treatment than radiation, which you'll hear about later today. Again, it's just heating it to kill tissue. It's a one-time outpatient procedure. It usually takes about 2 hours, and men go home the same day and usually have a catheter tube in the bladder for about 4 days to drain the urine. Okay, this patient, though, with a tumor in a different location, HIFU is not a good option for. But there are other methods of focal therapy besides that, including ones that we offer here at Stanford. So one I'll briefly mention is something called TULSA, or transurethral ultrasound ablation. This is a procedure that's done with a man laying in an MRI scanner under anesthesia. You can see this little cartoon. What we do is we put a transducer or a probe through the penis, through the urethra, through the prostate, and that transducer shoots ultrasound energy out into the prostate. So it's kind of cooking the prostate from the inside out. And then that can be rotated around within the prostate to cover whatever area of the prostate we want to cover, whether it's the whole thing or part of it. And this works particularly well for those tumors near the front of the prostate that we can't reach from the rectum, but we can reach from this probe starting right in the middle of the prostate. Another nice treatment, and shows that this idea of precision medicine, of tailoring our treatment approaches and what method we're going to use depending on individual characteristics of a man's cancer. So as a quick example of a patient that we've treated, say this is a 64-year-old man, had no symptoms whatsoever, as most cases of localized prostate cancer don't, but he was found to have cancer based on a high PSA blood test of 6. MRI was done and was abnormal, showing this black area that the yellow arrowhead is pointing to. A biopsy showed cancer, and he decided to have an MRI-guided focused ultrasound ablation specifically of that spot. And so what we see afterward, this is immediately post-treatment, that black area in the prostate is telling us there's no more blood flow. So that's the area of the prostate that was killed, but the rest of the prostate still has normal blood flow and will heal up just fine. And this is how these patients can have destruction of their cancer while a large percentage maintaining their normal urinary and sexual function afterwards. So last slide, a couple of take-home points. I think that both surgery and focal therapy are good treatment options. I think it's important to tailor the decision about which one we may do depending on a man's personal preferences as well as what is the nature of his prostate cancer. It's been widely shown that more experienced surgeons are able to get better results than less experienced ones. I think this is true both for surgery as well as these focal therapy methods. And the goal with any prostate cancer treatment is to try to both save lives while at the same time reducing harm related to treatment. And some new technologies such as MRI-targeted transperineal biopsy that we talked about and focal therapy can be helpful in achieving these aims. So thank you for your time and attention. I'll leave this up in the back, and I'm happy to take any questions.
Dr. Sonn. We do have a few questions over here. We'll go ahead and ask.
So a question, will HIFU ever become a first-line treatment?
I think that it will. It's a slow process to crack through the status quo and get to the point of widespread acceptance. I think we're seeing more and more focal therapy being offered, whether it be with HIFU or other methods of treatment. Our European colleagues have really led the way. HIFU has been available in Europe for 20-some years, and they are still pushing up against resistance, but have made more strides than we have here. So I think eventually, yes, we'll get to the point we'll see more and more focal therapy. It takes clinical trials. It takes getting insurance companies to jump on board and being willing to pay for these things. But I do think in the future, in select men, that this will become more of a standard treatment.
Another question, are there age-related guidelines for surgery and for focal therapy, both requiring anesthesia?
I think age is just one of the many factors that we take into account in making a decision about what treatment to offer. Generally speaking, we're not doing a lot of prostate cancer surgery in men, say, in their late 70s or 80s, who may do better with a less invasive thing like radiation or focal therapy. I don't really have any age cutoffs for men with focal therapy. We've done this in men in their late 40s. We've done this in men in their 80s. With regard to the question about anesthesia, generally speaking, somebody who's not healthy enough to undergo general anesthesia probably doesn't have the life expectancy who will even benefit from treatment in the first place. So if it's someone that's so sick, their heart is unhealthy enough that they can't undergo anesthesia, they probably don't need any treatment for prostate cancer.
Another question is regarding calcifications. If you find calcifications and treatments for such as HIFU or TULSA?
Sure. So the way I'll describe this to patients is that sound doesn't penetrate through rock very well. It can bounce off of stone. And that's what calcification is. It's basically like bone deposits that are in the prostate that are actually very, very common. Normally, they're of no consequence whatsoever. No one's going to feel if they have calcifications in their prostate. It doesn't really matter for radiation. It certainly doesn't matter for surgery. But for any of these ultrasound-based ablations, it can. That if you're shooting ultrasound, if your cancer's here, and your ultrasound source is here, and you have a big calcification or stone material, that's going to prevent that sound from getting where you want it to do and getting it hot enough to work. So that is one of the things that we look for in doing these TULSA treatments or HIFU treatments, to make sure there's not a big calcification in the prostate that's going to block that energy and make the treatment not effective. If that is the case, then we move on to some other method of treatment.
What about the trend of deaths?
There's a couple questions, and it's kind of hard to fully understand. So there is one from the audience, so maybe they can clarify. And there's two other similar questions. But there's questions around the trend of deaths due to prostate cancer and the adoption of age-related prostate screening. And then kind of, I think on the similar lines, is how much of an improvement is attributable to advancing the starting line in the period from detection to death. So I don't know if those two questions, I don't know how to summarize them well because I'm not, yeah. That's the best I can do. I don't know if someone in the audience who wrote the question wants to elaborate at all.
Sorry, I was muted. So there was a conversation in breast cancer a decade or so ago saying earlier detection, oh, thank you. In the breast cancer field, there was a debate about whether longer life expectancies associated with earlier diagnosis of breast cancer were less affecting the progression of disease and more about lengthening the period by advancing the time at which the stopwatch started observing the cancer's progression. And I'm wondering if there's a similar situation happening here. I asked the question before Lori's talk, and it suggested to me that that's at least partly true.
Mm-hmm. Yeah, so there's this concept of lead time bias. Are you just finding something earlier, and then you get a diagnosis 10 years in advance, and then you think, oh, they lived 10 years or 20 years longer. Is that really moving the needle versus if you just found it out later and they were going to live the same length of time? And that's why these trials are so important. I think one thing that's really meaningful to me, if you look, and I don't have this slide in my deck, but if you look at deaths from prostate cancer, when PSA screening began, you see this big uptick in diagnosis of prostate cancer initially, because all of a sudden we're finding all these men that were in the population that we just didn't know because of screening, and then that comes back down. But then what happened is there is about a 50% reductions in death of prostate cancer, and it really coincided very much so when screening took place. And then when screening fell out of favor, say starting in 2012, more so in 2015, the screening rates dropped quite a lot. That's when we started to see that death trend that was dropping flattened out and even started to go back up a little bit. And now screening's kind of coming back a little bit more, and the hope is that that will continue to drive back down. So I don't think it is all this lead time bias, but it can be difficult to interpret some of this data, and you have to think about what else could be going on besides benefit of treatment, and that is one thing.
Thank you.
Mm-hmm.
We have two more questions, and then we're going to take a break. First question, is focal therapy not for high-risk patients?
Generally speaking, so people have looked at this, when the best patient for focal therapy are in this, what we call intermediate risk group, the Gleason score of 7. And why is that? Well, The low-grade guys, we've learned over the last 20, 25 years, are going to be fine even if you don't do anything. So we rarely will treat low-grade prostate cancer anymore. On the other end of the spectrum are the high-grade ones, where people who have a higher chance of having cells having escaped the prostate and gone to bone or lymph node or things like that. Sometimes we can see that on imaging, and other times it may be microscopic, and only with more time are we going to find that out. There are several papers that have been published looking at focal therapy that show this nice progression where the guys with the lower intermediate grade cancer do best, and then the higher intermediate do a little worse, and then the high grade do a lot worse. And so when I talk to patients with high grade prostate cancer, I won't outright refuse focal therapy, but I'll often pretty strongly recommend a more aggressive treatment in that, it can be harder to detect recurrence or disease in the lymph nodes after focal therapy than after surgery. And the stakes are higher if it doesn't work completely. So especially in younger guys, I try to stay away from focal therapy in high-grade prostate cancer because of lower rates of success. In older guys, I'm more open to it, but as long as they recognize that the success rates are going to be lower.
Okay, last question. Is CyberKnife an effective treatment?
So I'll try to defer that one to later, largely in the radiation talk. CyberKnife is a very fancy and cool name for a method of radiation therapy that's generally done as a whole prostate treatment. So that fits in that when we talked earlier about the whole prostate treatment, surgery or radiation. Radiation itself has a lot of different flavors, either external or internal, and CyberKnife is one method of external radiation.
Thank you.
All right. Thank you very much, Dr. Sonn.